All right, perfect. Yep. All right. So this is my ICU clinical presentation. This is part of a project I had to do for a critical care class through Creighton University. I just really like this picture. That's not gonna work. Okay. All right, so who am I? My name is Kyle Essex. For those who don't know, I'm pretty sure most of you already know. I am a nationally registered paramedic. I also have my IBSC flight paramedic certification. That is your International Board of Specialty Certifications. I am a paramedic for Stony Brook Hospital. At Stony Brook Hospital, I do a combination of 911 calls as well as critical care interfacility transports. That's what IFC stands for. So we do our fair share of vent jobs. We have neurobleeds. We do strokes, aortic aneurysms, dissections, the spectrum at that facility. I also work for Northwell as a paramedic as well. And that's New York City 911. That's part of the FDNY supplement system. For those who don't know, FDNY, when they can't quite stock enough ambulances, they do actually contract out to local hospitals, and that's what I do in the city. So, little disclaimer, I wanted to let everyone know that all patient information has been redacted from the presentation in order to protect patient privacy. Obviously, HIPAA is very important, all of us know that, so we try to maintain that throughout this presentation. So this is a patient who is on ECMO, the ECMO patient.
It was probably COVID. ECMO is what they do.
What? All right.
Could you get me that little?
For anyone, sorry, we're having some technical difficulties with one of the Sequel Fire Department members. If you are able to, if you could mute your mics, everyone, just so we don't get extraneous noise. If you do need to ask a question, feel free to either raise a hand, write in the chat. I have someone helping me monitor the chat. If we're not getting to you, feel free to unmute yourself really quickly. Just say, hey, I had a question, and I'll do my best to get to all questions, okay? All right, so ECMO. What is ECMO? Extracorporeal membrane oxygenation. It is extracorporeal life support. It's a technique for providing prolonged cardiac and/or respiratory care to persons whose heart and lungs are unable to provide adequate amounts of gas exchange to sustain life. We're going to go a little more into depth with the VV or veno-venous ECMO, which is a lung support only. The heart itself is not bypassed. The surgeon can place a cannula in a large vein. Usually it's in the neck. They can actually do this through a single cannula, although the patient we're about to see has 2 cannulas. Obviously, blood's coming out of one and into another if you have 2, or they'll have 2 separate ports. So we can see it here. You can kind of see here, obviously, you have your oxygenated blood, your deoxygenated blood that comes out. You can see the flow. And for this one, all right, so we're going to watch a little video.
Saving a life is no easy task. Options for treatment vary based on the severity of injury, the prior health of the patient, the experience of the medical team, and the resources available within the hospital. For over 60 years, doctors rely on ventilators to supply oxygen and remove carbon dioxide when a patient's lungs or respiratory system fail. Ventilators oxygenate the body by forcing air into the lungs through a tube inserted into the trachea. As the ventilator pumps air into the body, the lungs inflate to mimic the process of breathing. When the ventilator finishes delivering a breath and the airway pressure drops, air is exhaled from the body and the lungs deflate. While this mechanical imitation of breathing can achieve the same goals as spontaneous breathing, it is not natural to our bodies and has its own side effects, especially at high pressures and oxygen concentrations. Although doctors don't exactly know at what settings a ventilator's side effects start to cause lung damage, they do know that an alternative treatment called ECMO can reduce injury caused by ventilators and foster lung healing in certain types of diseases. ECMO stands for extracorporeal membrane oxygenation, and it can carry out the work of a patient's lungs, heart, or entire cardiorespiratory system following trauma, infection, or surgery. It works by removing blood from the patient's body, pumping it through an artificial lung where it receives high concentrations of oxygen and carbon dioxide is removed before returning it back to the body. This technology sounds simple in concept. However, it is actually an intricate system that requires a team of specialists to watch over an ECMO response 24 hours per day, sometimes for several weeks. As with most life-saving techniques, ECMO and ventilators each come with pros and cons. Mechanical ventilation is a quicker method for oxygenating a patient. Standard ventilation requires less monitoring than ECMO, but it does come with moderate to heavy sedation and can cause lung injury at high pressures or oxygen concentrations. ECMO allows patients to be awake and moving during their treatment. By eliminating the breathing tube and ventilator, it removes a substantial irritation that drives the need for sedation. ECMO is not without its risks, but these have become more manageable in specialized centers. Texas Children's Hospital is fortunate to have on-site ECMO capabilities, with both the equipment and experienced staff to help a patient who needs assisted breathing, but can't take the strain of being on a ventilator. Texas Children's is an internationally recognized center of excellence for ECMO, with advanced experience in this field. For more information, go to texaschildrens.org.
As presented by Stony Brook University Hospital. So one thing that's also interesting, and unfortunately I don't have a picture for us here, but with VV ECMO, when they have that single cannula, when they do it in the neck, you can actually have someone who is walking, talking on ECMO simultaneously, which I think is very interesting. All right, so now we're going to go into the differences between VV versus VA ECMO. These are shorter. So again, with the VV ECMO, you are specifically supporting the respiratory system. You are not supporting the cardiac flow at all. All you're doing is oxygenation.
VA ECMO is often performed using centrally placed cannulas, meaning that the cannulas are placed in the great vessels in close proximity to the heart. This animation shows highly oxygenated blood from the ECMO circuit being returned to the patient through an arterial cannula placed in the patient's ascending aorta. With extreme cardiac dysfunction on ECMO support, if the heart is not beating and the aortic valve is not opening, blood being pumped through this cannula provides 100% of the patient's blood flow. In this scenario, there's no mixing of the two circulations since no circulatory support is being provided by the native heart. However, as the heart recovers and begins to beat, the aortic valve opens and blood flow from the native circulation now mixes with blood exiting the centrally placed arterial cannula. The composition of the blood distal to that mixing cloud will depend on the relative outputs of each of the two circulatory systems. In this scenario, blood sampled from most regions of the body would generally have a similar composition. The exception may be the coronary arteries, which, due to their proximal takeoff from the ascending aorta, may be primarily perfused by blood exiting the left ventricle and not by blood leaving the ECMO cannula. The perfusion of coronary arteries with adequately oxygenated blood can be problematic during VA ECMO support, even with centrally placed cannulas. Care should be taken to adequately oxygenate blood traversing the aortic valve if the lungs are capable.
So now getting into the exact patient that we had. So we're dealing with a 49-year-old male, so particularly younger individual. Patient is a full cook. Patient's weight's 168 kilograms, 6'4". He has an ideal body weight of 86.8 kilograms. So one thing to keep in mind, a lot of medications that we do based on respiratory or cardiovascular are based off of ideal body weights instead of the patient's exact weight. The reason being, just because someone has extra adipose tissue or muscle tissue does not mean that their lungs are any bigger or their heart is any bigger than someone that same size without those attributes. So it's important to be able to understand and know how to utilize your ideal body weight. It's used primarily with ventilator function, but there are some medications that will use ideal body weight as well. Easy way to calculate it, 50 kilograms plus 2.3 kilograms for every inch that person is over 5 feet tall. Obviously, that can go the other way for people that are under 5 feet. You would subtract the 2.3 kilograms. For females, you're going to subtract another 4.5 kilograms on top of that. If you want to memorize a separate formula, it's 45.5 plus the 2.3 kilograms for every inch over 5 feet. And that's how you calculate your ideal body weight. This patient also has a blood type of A positive. We're not going to do anything with that today, but it's important anytime you're dealing with an ECMO circuit or any sort of blood products that you are doing a cross type and match. This patient has no prior medical history. Now, one thing that we need to keep in mind as providers, just because someone says they have no prior medical history, it can mean one of two things. It can mean that they actually have a clean bill of health, or more often than not, it'll actually mean that they just haven't seen a doctor in a very extended period of time. So that's one thing to keep in mind. This patient has no known allergies. They are known to live a very sedentary lifestyle. This patient is morbidly obese. As you can also see, his actual body weight is almost double his ideal body weight. So he's carrying a lot of excess adipose tissue. And this patient openly admitted he has not seen a doctor in years. So that's an important question to ask when you are with a patient. If they say they have no prior med history, always ask, when is the last time you saw a physician? All right. So this patient on March 4th was admitted to a med-surg floor. He was COVID positive with shortness of breath. We've all seen it. We've all seen this patient. 5 days later, the patient had improved. He was supposed to be discharged. Luckily, the RN stepped up and had said that, he's not meeting the criteria to be discharged. He has orthopnea. For those who don't know what that is, as he is exerting himself, he is desatting. This is the main thing that we used in New York when we were talking about RMAing a patient, refusing that patient's transport. It was, do they desat when they walk, right? So that's an important statistic here, because now you're going to see why. So this patient also did not meet the criteria for a home oxygenator. So part of the consideration from in-hospital is, will insurance cover this patient for oxygen once they leave? Just because they cover it in-hospital does not mean they would cover it outside of the hospital. The very next day, the patient had an acute episode of desaturation and was brought to the ICU for monitoring. And 10 days later, the patient began to show diffuse infiltrates consistent with bilateral pneumonia secondary to COVID. The patient was subsequently intubated with an 8.5 endotracheal tube, 26 at the lip line. Placement is confirmed by chest x-ray. Chest x-ray is the golden standard in hospital. For anyone here who is a paramedic, you bet your butt they're doing a chest x-ray if you're bringing an intubated patient into the hospital. The patient was also subsequently switched from Eliquis to heparin, which we're going to note is going to play a factor later on in this discussion. Patient also has a Foley placed. Anytime you're intubating a patient, you do need to place some sort of method for them to urinate. He also has an OG tube because this patient needs to eat. and then has a central line placed. We don't do those typically in the field. There are some critical care organizations that will do central line placement. The IJ is common for in-hospital. It has a lower infection risk, but you also can do it subclavian blindly. You can also do it in a femoral as well. This patient also has an arterial line. For those who don't or are unfamiliar, it gives you instantaneous readings of a blood pressure. You also can draw your arterial blood gases off of that same line. And this patient also has a right midline, basically a very, very, very long IV catheter high up in the arm, in the brachial on the right side. So this is their chest x-ray. So we're going to go through some things here. One thing, anyone who's learned how to do a chest x-ray knows to look for patchy infiltrates. This is what ARDS looks like. This is what pneumonia can look like. This is what ARDS looks like. And you can see it all throughout here. It looks all fuzzies. This is your COVID. This is your COVID pneumonia right here, right? You can see it on both sides. Patient doesn't have any obvious broken bones or anything. You can see the EKG leads. Couple other things to note. If you can see this line right here that I'm running my arrow down, that is the endotracheal tube. That should sit between your T2 and T4. It's sitting right here about the 2 or 3, right, kind of in between the two, which is perfect placement for the endotracheal tube. You can see right here, that is the saddle, that is the carina. So that's important to know as well. That's how you know you have a very deep tube. You see a line coming down over here. It drops into the left towards the abdomen. If you were a betting man, you would probably say that's the stomach, and you would be right. That is their OG tube. On the right side of the patient, dropping down right here, right to where the heart starts, you would also be right if you said that was the central line. That is their right internal jugular central line. So again, chest x-ray showing the bilateral opacities. You can see the endotracheal tube right at top to T3 and the central line. You also see my existing mouse from when I was pulling up the chart. I apologize. All right. So 5 days after this patient was intubated, he continues to desaturate. And again, keep in mind, on a ventilator, we have very, very good control over a patient's oxygenation. So he is desaturating beyond the capabilities of a ventilator. There's a reason I showed you the ECMO machine before. It gets further complicated. So right at this time, the patient is also showing bilateral basilar pulmonary embolisms. All right, he is clotting off the bottom part of his lungs. Patient is subsequently placed on VV ECMO. Again, his heart is functioning just fine. There is no need for cardiac support, so we are going to support the respiratory system entirely. He has a right femoral inflow and a left femoral outflow. They were using the femoral lines. They were chosen due to the size of the patient. It's a lot easier to get those lines. Again, with the excessive adipose tissue, it can be harder to get those more desirable lines up in the neck. They also considered that they had the right internal jugular in that main vein up on the neck. This patient in particular was determined to be a good candidate for ECMO due to age. And we're going to go a little more into candidates for ECMO in a second. 2 days later in the early morning, it was noticed the patient was also bleeding from the left ear. Patient was sent straight to CT scan and had a left frontal lobe parenchymal hemorrhage. And we're going to show pictures of that as well. So now we're getting a problem with the coagulopathy. We have a patient overclotting in the lungs and underclotting in the brain. So this is how you would choose a patient for ECMO, is based on the Murray score. A score of 4 would be an ideal candidate. And this patient did have a score of 4 based on the severity of his ARDS. So his PaO2 to FiO2 ratio was 60. Chest x-ray, he had opacities in 4 lobes, technically 5. The PEEP prior to ECMO was greater than 15. So here is on a very, very high PEEP value. Again, PEEP is directly related to your oxygenation. The compliance was reduced per the physician. I did not see this. I did not see the patient prior to ECMO. So a disclosure there. This is how you score a Murray score. So you can see the PaO2 to FiO2. So again, remember, your PaO2 is a blood gas value. That's how much oxygen is actually in your blood system. Your FiO2 is based on what percent of oxygen. If you are on 15 liters per minute, you are on 100% oxygen. If you're on a nasal cannula of 2 liters per minute, you're at 24% oxygen. All right, so it's important to keep that in mind. And again, with 24%, when you're using these, you're using decimals. So that would be 0.24 so on and so forth. You have much better control over your FiO2 values on a ventilator. You can titrate it by the percent, as opposed to doing liters per minute. Does anyone have any questions on anything so far? Let me take a quick pause right here for any questions. All right, we'll continue. The short diagnosis: this patient has a severe ARDS secondary to COVID. He also has a pulmonary embolism and a parenchymal bleed. So we can already see the level of this ICU patient we're working with. Gonna play, not gonna play. There we go. Another quick short video. This is specifically ECMO for the COVID patient.
When the COVID pandemic began, it was obvious it was going to be very serious, very big, worldwide in scope. And we didn't know if ECMO would have a role in this particular disease. The way we addressed that was to modify the registry in order to collect data from the time patients first went on. And this proved to be exceptionally valuable.
When the COVID-19 pandemic began, we weren't sure what the role of ECMO would be. As it progressed, we recognized that there were going to be severely ill patients who were going to fail ventilators and might need the support of ECMO. And so the ELSO registry called upon its collaborators to transition to entering data into the registry in real time. And that helped us address that question in our current publication. What we found in that publication was that patients who required ECMO support had a survival rate of over 60%, which is really similar to what we saw in recent landmark publications such as the Eolia trial that looked at the role of ECMO in patients with acute respiratory distress syndrome. And the survival was similar there. It was also similar to what we've seen a little bit further back in other observational studies, considering the role of ECMO in the H1N1 pandemic of 2009. And so when we're talking about these patients, we're talking about sick patients, patients who have largely failed the ventilator in their provider's opinion and have gone on to the support, but nonetheless are surviving, as we've seen in other studies.
All right, I believe that's it for the videos. We're going to start getting moving a little more with the rest of the slides. So this is the patient's EKG. I figured I'd start with a modality that we're all familiar with. So let's see what we can see on here, right? So first we'll start with a rhythm. We have a sinus rhythm, right? Next thing we're looking for, maybe the axis. So this patient does have a little bit of axis deviation. If I were a betting man, I would say it's probably on that fine line of a pathologic and physiologic based on the axis here. The big thing to note here is that they do meet LVH criteria based on voltage. If you look in lead 1, it's above 13 millimeters of elevation. And the other big thing here too, you have S1, Q3, T3, which is consistent with the pulmonary embolism that we saw later on. You also do have a biphasic T wave in V4 and 5, and inverted in 1 through 4. So now we're going to see some.
TJ said he couldn't see the whole EKG.
We'll go back. All right.
And Vitaly asked, did David Brenner teach you that?
David Brenner taught me everything I know about EKGs. Right. So here's the 12 lead itself. Again, you can see inverted T waves in V1, V2, V3, V4, biphasic in 5 and 6. So having some trouble with repolarization. You have the inverted T wave in 3. You have a Q wave with an S wave, indicative of that pulmonary embolism. Again, that LVH is up here. Your AVL is above 11 or pretty close to 11 millimeters. I wouldn't call it on that, but on lead 1, over 13 millimeters is indicative of LVH. One thing to remember when analyzing your 12 leads is you're not always going to see it If you look purely in your precordial leads, you would have no idea this person has LVH. One of the reasons behind that is all of this is reduced because of the amount of adipose tissue on this patient. Your high leads, the way that they detect it, it's better at picking up your high lateral hypertrophy. So it's one thing just to keep in mind. All this stuff is going to be reduced purely because the patient has excess adipose tissue. So now we're going to see some CT scans. So we can see some slices here. So 3 slices. These are in the lung window, right? So you see the white over here. Black is air, black is good. White here, this is your pulmonary embolism, bilateral in the bases. So you can see that massive PE taking out that lower lobe of the lung, and you can see it's absent in the middle and the upper lung fields. Now we're going to go to the neuro. So the first thing you're going to see two neuro, 1 CT, 1 MRI. And this is prior from the patient. This was actually, I believe it was a year or 2 before this incident. He happened to have a CT scan. So you can see these little white things in the brain. Those are just calcifications. It's pretty common. Maybe not at age 49, but they are pretty common. Here you can see all the vasculature from the MRI. This is with contrast. You can see the circle of Willis for anyone that's familiar. Again, that's your body's safety mechanism for strokes. You have a clot here, you're still able to perfuse the whole brain, which is nice. And now you can see that parenchymal bleed. All right. Again, the way that you read the CT scan of the head, that is the left side, and that is in the frontal lobe parenchymal. Right. You also note that there is no midline shift. You can tell that. You can see this little bone structure come in and down here, and it goes straight between those 2 ventricles, right? These are called ventricles, without any shift. So no midline shift, which is a good thing, and no collapse of the ventricles, which is a good thing as well. It's important to pick that up because we're going to talk about that for one of our next patients. So these are the ECMO settings. Again, ECMO nurses are very, very specifically trained. Perfusionists also will run this. So this is kind of above the level of care that we are going to provide. But it's just something to be aware of. So the patient, one of the really cool things with ECMO is you can very tightly control the patient's temperature because you are controlling the temperature of the blood in the oxygenator itself. And we'll go into the parts of that in a minute. We have the actual flow rate, right? 5 liters per minute. That's the flow rate of blood going out from the ECMO machine. You have P vein, which is the pressure in the vein, which is -98. This is how much you're sucking out from that left femoral vein, that cannula. The goal is -100. If you go higher than that, you can actually collapse the vein entirely, which would be a bad thing because you would completely shut the whole system down. A pressure in the artery is 132. That's your outflow pressure. Your P int is the internal pressure within the system itself. So you can see that delta P, that's your pressure loss from your outflow. And then you have your SpO2. Again, it looks like a low number, but you have to realize this is in the venous system. 60 to 80 is ideal. All right, so not your PaO2, that's your SpO2. And the RPM of the oxygenator is 3,200. This particular oxygenator had an FiO2 of 1.00. Again, that means basically all of the hemoglobin that's going in, again, it should be 100% hit by that oxygen. This sweep flow, again, we're not going to get into the nitty-gritty details of this. What you need to know, the higher the sweep flow, the better you are at clearing the CO2, right? So it's important not only to oxygenate the patient, but to clear off the CO2. And this is another thing that's very interesting with ECMO. Because you can closely titrate your FiO2 as well as your sweep flow, you can independently titrate your oxygen pressure within your system, as well as removal of CO2 within the system. Also, any patient on ECMO, especially at this hospital, is getting an ABG, an arterial blood gas, every 4 hours with an ISTAT. This is a picture of the maquette machine. This is the actual one that the patient was on. Values are a little different when I took this picture, but you can get the gist. This is what it looks like, what they can control, what they can't control. And this is the full machine. Again, you can see that temperature regulator on the bottom. You can see the oxygen on there as well. And this is the oxygenator from the back. You can see all of this. This is where the blood itself is getting oxygenated. You can see the two different colors. Let's see if you can figure out which one's oxygenated versus non-oxygenated. All right, the darker one obviously would be the non-oxygenated blood. This patient was still on a ventilator, even though he was on ECMO. The main idea behind that is you want to protect the lungs from atelectasis and any permanent damage. So this patient is ventilated on AC mode. For those who don't know, what that means is there is a minimum number of ventilations that are prescribed to the patient. Let's say it was, I believe, 10 for this patient, and we'll go into that in a second. Any breaths that this patient decides to initiate over that will still be at the volume that is prescribed. So if we say this patient needs 500 mLs of air, when they initiate their own breath, they are still pulling that 500. Other modes will do different things. If you want to get more into that, I suggest taking a class on ventilators or reading a book on ventilators. So we already see the ventilation on this patient, 150 mLs. That's barely more than the dead space. So he's not really getting any oxygenation value off of this ventilator. It's purely just keeping his lungs moving. And 10 was the prescribed respirations. All right, this is his pressure setting. So he has bi-level pressure support. So I know we use CPAP in New York in the field, which would be the equivalent of like 10/10 or 5/5 is the settings that we'll use in the field, but you can also do bi-level. What this does is as they inhale, they're getting an increased pressure and it helps their oxygenation while also allowing them to offload. He has an I to E ratio of 1 to 5. I'm sorry, it should be 1 to 1.5, I believe. FiO2 is at 80%. Again, the FiO2 in this, it's minimal. Again, he's getting his oxygenation from the ECMO, not from the ventilator. Here's some of your pressure values. So he has good lung compliance. The PIP is not that much higher than the P-plot. PIP would be your peak inspiratory pressure. Your P-plot is the pressure that your lungs will stay at for the duration of your inhalation value. The PIP, as long as you keep it under 35, you're in the clear. The P-plot, under 30. So that's where you will do lung damage on a patient. If you break that PIP value, that's when you're going to pop a lung. The P-plot is more long-term damage. That's a very oversimplification of it. And again, just calling that, it's not even 2 mLs per kilogram. For people doing ventilator work, usually you're going to start somewhere between 5 to 10 mLs per kilogram is your safe volume. And this is the Draeger, similar to the vent that we're using with this particular patient. All right, so these are the labs that I presented before. So something to keep in mind, if you didn't write it down, I would recommend doing that. It'll help you make sense of a lot of the rest of the lecture. This is a common way to write down your labs, this little kind of fishbone looking thing. You have your sodium, your potassium, you have your chlorine, your CO2, your BUN, your blood urea nitrogen, your creatinine, and your glucose. The way I remember it is you have your you have your, up in the sodium, you have your plus, you have your plus in the potassium, you have your minus, you have your minus, you have all things renal, and then your glucose. And that's how I remember it. So these are all your normal values. Over here, you have your CBC, so your white blood cell count. Again, they can be elevated or depressed as a sign of infection. Again, depressed if the infection's kind of taking over all your white blood cells, and if you have a really good immune response, you might have an elevated white blood cell count. Your hemoglobin is purely the amount of red blood cells that are in the system. Your hematocrit's the percentage of your hemoglobin to plasma, and you have your platelets, which is your ability to clot. Over here, you have your coagulation studies, which is going to tell you basically how you're going to bleed. Your INR is probably one of the more consistent ones. That's usually what they use for Coumadin, is your international normalized ratio. And they'll go for a therapeutic ratio of about 2 to 2.5. All right, over here you see your ABG values. Again, that's how you're going to tell your acidosis, your alkalosis, and all of your arterial blood gas values. All right, we're gonna go into that in a minute. So this is the patient's morning labs. I tried to star most of the things that are important. One thing we can see, his sodium's high, right? Normal high end is 145. Potassium's 4.4, chlorine's 112. Again, that's a little bit high. Bicarb also high. Now you have your BUN is 85, your blood urea nitrogen, right? And you have your creatinine of 1.01. Now the BUN is very, very elevated. One thing that we'll look for in this is a ratio of your BUN to your creatinine. If your BUN to creatinine ratio is less than 20, your renal failure is likely to be intrarenal, within the kidneys themselves. If your BUN to creatinine ratio is over, it is pre-renal. This patient is having renal failure, indicated by that BUN, but is before the kidneys. It is from something else going on. So now we're getting into the CBC. The big thing of note is he has a low red blood cell count, perhaps from lysis from the ECMO machine. His hematocrit is also low. He is having difficulty maintaining that level to be able to properly circulate oxygen. The platelets are low, right? So 150s are low end. So he's having what's called thrombocytopenia, which means he has low platelet count. So his ability to coagulate has been diminished beyond just his PTT. So his PTT is a little low, but nothing crazy, right? And that's the measurement they're using to see how well he's going to coagulate. One thing also, when we were talking about that chest x-ray we saw before, is to keep in mind, it's a little bit of a poor chest x-ray quality. The patient was not positioned very well. He's lopsided, and perhaps that was due to weight. And again, that's just reanalyzing that chest x-ray as well. Patient had an ABG 7.44, which is good. He's within our range. The CO2 is high. The PO2 is low. One thing that we use in the critical care field with your PO2, the oxygen hemoglobin dissociation curve is something very important. I'm not going to get into that here, but something to keep in mind. If your PO2 in your blood gas is 40, 50, 60, it usually is indicative of a 70, 80, 90% of your pulse oximetry. So someone with a PO2 of 54 is probably saturating around 84%. It's the most linear part of that dissociation curve. And then your bicarb also is elevated. So if we were to do a quick analysis, this is compensated metabolic alkalosis. Compensated because he is within a normal pH range, but you can also see that the CO2 and the bicarb are both out of range. All right, again, if you want to get more into that, that's going to be beyond the level of our presentation here. And again, the FiO2 is at 1.0, and again, that's based on the ECMO as well. Vital signs are as follows: 128/56. He is in sinus brady at 49 with a pulse oximetry 85%. There you go. All right, these are the patient's meds. The patient is on Precedex and Versed for sedation. The patient's receiving potassium phosphate. So this is something interesting to keep in mind with the patient. He's on 20 milliequivalents of this potassium phosphate. Why? The potassium had a low phosphate before. Now, the two options to give a patient phosphate are sodium phosphate and potassium phosphate. Now, we saw before the patient, if we go backwards, the patient had a potassium of 4.4, which is within range, and the patient had a sodium of 151, which is already elevated. So why would we give him more sodium if he's already elevated? We have a little wiggle room on the potassium. So what do? We gave the potassium phosphate instead. Patient's also on fentanyl. One thing that's important to remember is giving analgesia anytime that we use intubation. Intubation is one of the most painful experiences a human can have. Do remember, sedation does not mean analgesia. So even though you're sedating someone and intubating them with Versed or etomidate, it's also important to pre-medicate that patient with fentanyl as well. Again, we can be a little limited depending on what our area will allow us to do, but it might be something worth considering if you do have to take someone's airway in the field, give them some Versed, call for it, be the nice person that doesn't aggressively take this airway painfully. All right, and the patient's on Nimbex, which is a paralytic as well, because obviously you don't want a patient moving who's on ECMO. All right, non-drip meds, verapamil, omeprazole, Senna, polyethylene glycol, vancomycin, and PRN, insulin or dextrose, and heparin as well. Heparin was withheld once they found the neurobleed. Heparin's usually for any ECMO patient to prevent them from clotting up the machine. They used an Alaris pump. It's similar to what we use at Northwell as well. We use it at Stony Brook as well. It's probably one of the better pumps that you can get. I'm very comfortable with it. It's very intuitive. So for the Sequel Fire Department people, that's what they use at Glen Cove, Manhasset, all those. So this is the iStat. This is what we use for ABG values and our BMPs, Q4. You can see us using it. Ooh, blood, gross. And that's the printout from the iStat as well. Okay, so it's just copying from the prior slide. All right. So Precedex was stopped due to bradycardia. Again, now we're going to reduce the sedation. All right, which has its inherent problems, but we do need to make sure that his heart rate's staying above a certain threshold. His heart rate's dropped below 45. They were not comfortable with that. I wouldn't be comfortable with that. So they're going to go ahead and remove that Precedex. You can also see here, vitals coming down, blood pressure going down, pH going down as well. Everything kind of coming back into range in that realm. Still hypernatremic. Potassium still good, so it was a good choice sticking to the potassium phosphate. Glucose is good, hematocrit's going up, hemoglobin's going up. Urinary output's over 150 mLs per hour. One thing to keep in mind, any patient in renal failure, you want to keep that urine output above 150. Your basic calculation for that for a regular patient would be 0.5 mLs per kilogram for an adult, 1 for a pediatric, 2 for a neonate. But for anyone in renal failure, rhabdomyolysis, any of those, you want it over 150 mLs per hour. Dental hygiene is also important. This is how you prevent ventilator-acquired pneumonia. So this patient's having dental hygiene performed every 2 hours. Because again, if you're sedated, intubated, and on ECMO, you're probably not brushing your own teeth. And if you are, that's very interesting. All right, now we're getting a hypertensive patient, okay? So again, this is one of those side effects with the brain bleed. He is having increased intracranial pressure. So with that, you need to be able to perfuse the brain. So what happens? The blood pressure goes up as well. The other thing to keep in mind, his heart rate's going up and his blood pressure is going up. Also could be a sign of poor sedation. So again, anytime you've sedated the patient, you're doing a long interfacility transport. Let's say they're paralyzed, but they're not sedated. You're going to start seeing those increase. You're going to see their heart rate go up. You're going to see their blood pressure go up. That's going to be the first sign that they're not adequately sedated. So again, 73 might not be considered tachycardia. It's not considered fast, but you have to, relative to the patient's baseline. The patient's baseline is 45 to 60, and we've seen it drop below 45. So him at 73 is pretty fast. That's one thing to keep in mind. And that blood pressure coming up also is something to keep in mind. The patient was then bolused 20 mics of fentanyl, and Precedex was restarted. The vent FiO2 is also increased to 90%. Again, they're not really getting much off of the vent, but at this point, they're trying everything to get whatever oxygenation they can. ECMO is already at 100%. Fentanyl was then increased to 150 micrograms per hour, and Versed was increased as well. Vitals were retaken. You see a lowering of the blood pressure, a lowering of the heart rate. Pulse oximetry is going up slightly, but we'll take it. We'll take what we can get. All right, and these are just some of the meds that we work with on a daily basis. We have access to these meds in New York. So again, going through, this is the same settings that we saw on day 1. Not too much has changed for day 2. All right. I'll move this down. All right, so some alternative treatment options. So you could consider propofol. Propofol is used a lot in the hospital. It's very easy on and very easy off. Here's the problem with propofol for this patient. Propofol is very, very high in triglyceride content. These lipids will actually build up into the corners of the ECMO oxygenator. I'm going to show you that with a picture. It's a little easier. So you can kind of see the corners there. Bam, 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 bam. You'll actually get propofol building up fatty deposits in those. Obviously, now you're dealing with possible thromboembolisms, or it could also jam up the machine, either of which not a good idea. This also can happen with higher doses of fentanyl. So the other thing with sedation, instead of adding withdrawing Precedex, I thought personally the Versed drip itself could be increased. You're dealing with less, crossing medications, less confounding factors. The big problem is the lowering of the heart rate. So again, you have to realize all the pluses and minuses of every med for every patient. Hypertension. So the hypertension, when this patient had it, needs to be addressed. One real easy hypertensive that will preserve the heart rate is nitroprusside. Nicardipine and labetalol are probably your three best options. Nitroprusside is selective, very selective for BP. The big risk is exposing this medication to light. For those who don't know, nitroprusside, when exposed to light, basically turns into cyanide and you will acutely poison this patient. The problem with that, if we're talking about our interfacility, is it's a lot harder to maintain that out of light while you're moving the patient around. The bag itself is usually wrapped in aluminum foil, which again, it's just another hazard when you're going from place to place, but it can be done. Nicardipine, that's what we would use at Stony Brook. It has a little bit of an effect on the heart rate, but a lot less. It's also less of a concern for a patient on ECMO. Cardiac activity preservation is a concern purely because our patients on VV ECMO, again, they have no cardiac support right now. With nicardipine, one thing to keep in mind with any brain bleed patient is you don't want them to have a normal blood pressure. You want their systolic to be between 140 and 160. Again, they have increased intracranial pressure and you have to overcome that to properly perfuse the brain. If you drop their BP to a normal level with an increased intracranial pressure, you're not able to perfuse the brain. So labetalol. Labetalol also is very, very good at BP modulation. The problem with labetalol, or not so much a problem, the one thing I'll say it's a good thing for this particular patient is you could administer it as a PRN dose instead of titrating it on a drip. Nicardipine and nitroprusside tend to be titrated on a drip. Labetalol, it's more of a bolus. You can do a labetalol drip, it's not as common. So for a patient like this having acute hypertensive episodes, it actually might be a good idea to do labetalol as your pressure support. And these are those medications. All right, so this patient's being trialed off of the paralytic. You have to be off the paralytic to have a neuro consult. So now you can see their current Versed dose, their fentanyl dose. No more paralytic. Very excited. Patient's waking up. Not exactly. So one thing to keep in mind is the train of four, and this is how they moderate sedation, and really paralysis is what they're going for. So usually for a sedated patient, for an intubated patient, they're doing the train of four on the head. They're trying to trigger the orbicularis muscle around the eye to fire. They can also do it on the ulnar nerve, but again, be aware this patient probably has multiple IVs, arterial lines, which is why they usually do the face for these patients. What they do is they gradually will increase the impulse, the intensity, and look for twitches. Now, if you want to be able to do a neuro, you want to have at least 4 twitches, right? So that means 0 to 75% of that kind of where that paralytic would work is being used, right? So if you give someone a paralytic, but they're using Nimbex in this particular situation, if you have 4 twitches, you might have no paralytic bonding all the way up to 75%. If you have 3 twitches, you are at 75%. 2 twitches, 80%. Your 2 to 4 is what you normally want for a patient that's sedated, intubated, and paralyzed. All the way up to 1 twitch, you don't really need it, but really 1 to 4 twitches is going to be adequate for your RSI, your rapid sequence intubation. But this is really common in the ICU. They do it periodically to make sure they're maintaining the proper sedation, the proper paralysis for a patient. So now we're going to see some trends in the BMP and the CBC. So you can see patients increasingly hypernatremic, chlorine's getting a little more out of whack. The bun and creatinine are kind of coming a little bit back in range. Not too much different. Platelets are going back up, less thrombocytopenia, perhaps from the change in meds. So So again, the change in bed setting, it's not much. The patient's controlling this volume, they switch the mode. So you're going from a volume controlled mode to a pressure controlled mode. So as long as this patient's able to maintain whatever the prescribed pressure is, he's actually pulling a little bit more volume. Increasing the rate slightly based on your I to E ratio, but in reality, we're still at a respiration rate of 10 for the most part. Patient was pulling a breath every so often because the paralytic is no longer being administered. All right, and again, the ECMO settings, again, not too much change. All right. Alternative treatment options. Should neuro want to do intermittent consults? It could be beneficial to change the paralytic strategy for a shorter acting paralytic such as rock, or better yet, sucks. Again, we do have to acknowledge succinylcholine does carry the added risk of hyperkalemia. It also carries the added risk of a malignant hyperthermic reaction, which for this patient would probably be unable to overcome. For those who are unaware of succinylcholine, that malignant hyperthermia, if you ever administer this medication to a patient, they become acutely hyperthermic, and not just 101, 102, you're talking 107 and up in a very short period of time. They're probably having malignant hyperthermia. The only thing that'll actually get them out of it is a medication called dantrolene, which is carried by the cartful, and you will probably use the bulk or all of that cart for a patient. They're stocked usually in the OR. So this patient, because he's been trending at 4.1, we're giving him potassium, still 4.1. He's probably a low risk for hyperkalemia. So perhaps that would be a good one. Succinylcholine usually has about a 15-minute off time. Rock's a little bit longer. It would definitely last long enough, and you'd have an off time of about 45 minutes. And these are two medications we do carry at Stony Brook. And Nimbex was the medication they were on. Blood thinner. So this patient was changed from Lovenox, or low molecular weight heparin, to Eliquis. Possibly could have made the difference with the anticoagulation causing that pulmonary embolism. Also potentially could have had that same effect to cause the parenchymal bleed. So one thing they were giving, it was a common thing to give COVID patients heparin once they started figuring out that it was a problem with coagulopathy. So this is a great chart for kind of figuring out the different pathways. You can see where all these meds kind of come into play. All your common meds. So not that you have to commit this to memory, but it's something to be aware of. Your heparin works in a very, very different way than your warfarin. Are two most common that we see. I think switching from Lovenox
Dr.
to
Essex, I have a question.
Yes, sir.
How many units of heparin were they administering?
I do not remember. I know they were doing the sub-Q boluses. They weren't doing a drip, but they had stopped the heparin by the time I got there. They had switched to an Eliquis regimen.
10-4.
All right, I apologize. I do not have the answer to that question. So this likely was a case of overtreating. I think switching the patient to Eliquis might have been a little preemptive. The patient wasn't stable enough to make that change, but that's why they make the big bucks, and I'm sitting here presenting to all of y'all. All right, so unfortunately this prognosis, the best prognosis for any intubated patient is really made about 8 days post their initial intubation. 8 days out, they have a good idea. Are they coming off? Are they staying on? Unfortunately, most of your ARDS patient, almost 60% of them are going to have mortal complications from this particular ARDS. This particular patient also is basically at this point in MODS. They're in renal failure. They are completely shutting down most of their systems. So I would actually put this patient's mortality rate is probably very, very close to, if not 100%. So unfortunately, this patient really is never going to experience life. I would have to say this patient's likely passed soon after my interaction with him. Again, with the existing bleed that basically had to be left untreated, would have permanent neurologic deficits if they were to recover. So unfortunately, the social and psychological ramifications are really going to fall to this patient's family and friends. There was only one contact that visited this patient during his stay and did not have a large base of contacts. So the psychological impact is isolated to only a few people. But again, this patient likely will never be able to comprehend everything that's happened. So some intrigue about this case. So one thing that they want us to talk about as well is what made this case interesting. Duh, it's ECMO. ECMO is the coolest thing ever. It actually, one thing real quick before I move on. I think one of the things that's really cool about ECMO is it really challenges what our definition of life is. You know, you can have a patient on ECMO whose heart is completely stopped, whose brain is completely stopped, and they are still technically living. They're utilizing oxygen, they're off-gassing CO2, and they can be completely cardiac dead and brain dead, which I think is fascinating. And it's really forced the medical field to challenge the definition of what is life, what is death. So this is another thing I find very, very interesting. We see here in France, field ECMO. About 2 years ago in 2018, they actually started doing this in Albuquerque, New Mexico. Oh, I'm sorry, 2020. They actually have 2 ECMO ambulances out in Albuquerque, but they are starting to do field ECMO. You could argue the efficacy of doing field ECMO. How do you determine a patient's candidacy other than just cardiac arrest? How do you get them to be able to do this in a fast enough time? But it is one of those things that's interesting, and it's definitely pushing the bounds of what medicine can be. So hopefully we all at least learned a little bit about ECMO, how to work with an ECMO in-facility team, understanding complications, clots, contraindicated medications, venous collapse, protective ventilator strategies, and how to use an ISTAT. These are all things I learned. Reviewing sedation titration, and for those intermittent neuro exams as well, especially with that neuro bleed. How to use the train of 4. ARDS management. All right, any questions on that patient before we go on to the next one? Next one's a bit shorter, I promise. No questions. You all know everything there is to know about ECMO. All right, so.
Dr. Essex, I have a question for you.
Go for it.
For MFI, which you were referring to before, kind of, obviously the use of Versed, if we don't have fentanyl, would you even use morphine, or what dosage would you use?
So do you have etomidate as well?
I was going to say, you better have an answer for this one, please.
So here's the problem. MFI is really, it's a damned if you do, damned if you don't. It is an improper use of medications for a pseudo RSI style intubation. The big thing is you want to increase your first chance pass rate. For me, I use a bougie. I use a video scope when I have access to one. And I think that's very important. I think using paralytics is another way. You reduce the patient's aspiration risk. If you don't have access to fentanyl, morphine. So I do agree they need some sort of pain management. Here's the thing. You have to make sure you manage this patient with their hemodynamics in mind. So if you have a patient who is starting out at 100/60, personally, I would actually go for ketamine and use ketamine for an RSI over my Versed, unless I found another contraindication to ketamine. You want something that would support that blood pressure. If you, again, all you have is your Versed and your morphine, and that's what you have to do. You have to do what you have to do. Unfortunately, it's kind of a damned if you do, damned if you don't, as I said. What I would probably do in that case is you want to resuscitate before you intubate. I would probably be using push dose epinephrine or even a noradrenaline drip to get that blood pressure higher, knowing I'm going to tank it. Be proactive, don't be reactive. You don't want to tank their pressure down to 40 over 20 because you'll throw this patient into arrest. It's much better to be proactive. Create a little bit of a hypertensive situation with this patient before you then tank them. Does that answer your question?
Okay, you know, when you need to intubate.
Sorry. Yes, you danced around the answer, but I understand what you're saying.
You wanted exact doses of how I would do it?
No, that was fine. I'm just busting your balls.
All right. I have a question for the in-person crowd, so I'm going to repeat it back to you in a second, okay?
If you're gonna need to MFI someone, you're gonna need to pretty quickly.
Mm.
You might not have time to do the shows or Noracid or whatever. So, I mean, you can always precious couldn't try once you intubate,
Mhm.
right? But introducing morphine after or before is risky. But you have to get the airway first, and then maybe you can fix the pressure.
So the question that was posed is, usually you have to do an MFI procedure very fast. How do you have the time to do this resuscitation before you do the intubation for a patient that's in a crashing airway algorithm? If this patient is in respiratory failure versus a true MFI RSI situation, I think really makes the difference. I think if you're in a crash airway algorithm, you're in a very different situation. I still think it's important to resuscitate before you intubate as best you can. The big thing is you want a SpO2 ideally actually above 94% before you do this intubation. And I think a lot of times we actually have more time than we think if we do the proper resuscitation. So as much as we want to get that tube aggressively and be aggressive with the airway, it's also important to remember what happens after we get that airway. Now, if the patient, there's no way that we can maintain his airway for more than 15 seconds, they're in respiratory arrest, that's a completely different situation than your true MFI, I would argue. So I think the patient you're thinking about is more of a crash airway. They're basically already in respiratory arrest. They're gonna arrest. Severe anaphylaxis, I think you would have, as much as you want to control this airway, I still think with your initial epinephrine push, IM, you could then go and you should still have the proper time to administer the meds properly and do a proper resuscitation. It gets fuzzy because we have to call medical control for a lot of that stuff. Again, it's, ideal medicine, you were doing this full resuscitation before. Obviously, we have to dance with medical control where we are here in Long Island. I'm fortunate that in at least one of my two services, I'm given the liberty to make those calls on my own. But we do have to, unfortunately, do that. Something like epinephrine, you might be able to, off the record, get away with doing your proper push dose and doing a proper resuscitation before intubation. But perhaps you could be doing that while you're calling them. Do all of your interventions while you're calling, knowing the clinical course of action. Hey, I'm calling for orders for this, and this, while you're doing your IM epinephrine, your albuterol, your duoneb, and all of that as well. Probably how I would try to do it. Again, we're talking in a very easy, we're sitting down, we're comfortable manner. We're not having a patient crashing in front of us. So easier said than done. But ideally, you do want to resuscitate that patient before you bottom them out, especially someone who's in anaphylaxis where they might be already leaking and really susceptible to hemodynamic compromise.
Dr. Essex, I have another question for you, sir.
Go for it.
How do you do your push dose epi? Do you use 1 ml of the 1 to 10,000 and then just draw up 9 cc's of normal saline?
Yeah, so that's how I do it.
Okay.
That's how I do it, so you can precisely measure it. Another way that it's done.
That's how they tell you to do it.
Mhm. Yeah, so that's how you can do it. That's as Mr. Baskin said in the in-person group. That's how we're told to do it, based on the REMAC as well for both the city and Nassau County. You can also put a 1 milligram into 1,000 bag and draw out of that. That being said, I've never had to push that much push dose epi. I don't have those long transports, and if you do, you should probably be starting a norepinephrine drip at that point. So it's really just to tide you over through the intubation attempt or through until you can start a norepinephrine drip. So I think doing that one is usually fine. You also could do like, I know it's a big thing for some providers, is the dirty epi drip for cardiac arrest, is you actually put the 1 milligram into a bag and you run it, which gives you that similar concentration, but it's running a little more consistently. All right. All right, so we're going to move a little bit on to this neuro patient. So one of the things that you can see here, obviously you can see all the anatomy of the brain identified. You can also see all of the different types of monitoring, right? So here's your ventricular. Is it tunneled through the cranium? Is it straight shot in? Your bolt and all of that jazz. You can see the ventricles from this coronal view. So this is our neuro patient. This patient's a 6-year-old male, height of 6'1", weight 123 kilograms, ideal body weight 75.3. Again, keep in mind, ideal body weight is really important for your ventilator. Patient does have an allergy to insulin and metformin. What I was told seems kind of weird, at least the insulin part, but so be it. Past medical history, coronary artery disease, diabetes, hypertension, congestive heart failure, renal disorder, sick sinus syndrome, and has a history of prior strokes. This patient is 60 and they're in a nursing home. Patient was brought into EMS by a SNF. SNF is skilled nursing facility, for those who don't know. Found with a GCS of 3, unknown time of unresponsiveness, has an initial blood glucose of 213. So quick stopping there. 213 doesn't seem high, but just do be aware he can be in DKA as low as 150. So don't rule that stuff out just because of what looks to be a moderately okay glucose. Patient has a left humeral IO, placed on non-rebreather 15 liters, has a left brachial midline catheter placed. The initial working diagnosis was a UTI. The patient does have cloudy urine when they inserted the Foley. The ED, and again, I'm going to start things that I think are important. The ED attending refused to intubate this patient. A neurosurgeon happened to be walking by the ED, talking, shooting the shit with one of the other doctors, passed this patient, noticed an obtunded patient lying in bed aspirating. Patient had a rapid neuroconsult, was brought stat to CT and OR, and a ventricular shunt and ICP monitor was placed. That is a ventricular bleed. That is a very aggressive ventricular bleed. All right, and again, remember with the CT, that's actually the right side of the brain. Patient was brought up from the up to ED from the OR. I'm sorry, up to the ICU, I should say, from the OR. Endotracheal sheet was 31 centimeters in the lip line. Patient was placed on ICP monitoring, initial pressure of 16. Your ICP should be anywhere between 5 and 15. The neurosurgeon prescribed a set pressure of 12 millimeters of mercury. Here's what that does, and I'll show you the apparatus in a minute. When that pressure hits 12 milligrams, it will automatically start to drain. We were also instructed drain no more than 15, should be mLs per hour of CSF. Patient's initially hypotensive, has a MAP of 53. For those who are unaware, there are a couple ways to calculate MAP really quickly. What I do is systolic minus diastolic divided by 3 plus diastolic. If you actually look in arterial waveform, you'll understand why. The current intracranial pressure is 11. We're given essential perfusion pressure of 42. So your cerebral perfusion pressure will be your MAP minus your ICP. It's what pressure is getting up to the brain, right? Normal should be between 50 and 90. This is also why it's important if you're hypertensive, it perhaps could be compensated for increased cranial pressure. If they have an ICP of 30, again, you're going to need at least a MAP of 80 to get the blood up to the brain. Otherwise, you're not even getting to the brain. Patient has sinus tach between 110 and 120. Patient had initial pulse oximetry of 82 on an FiO2 of 100 and intubated. Again, 1.00, it's given as a percent. Intubation. Diagnosis, ventricular bleed. Nice and easy. Down and dirty. The initial temperature is 40 Celsius. Patient's being treated under a sepsis workup. Lactated ringers is started at 30 mLs per kilogram. If you look at any sepsis workup, that's their initial bolus. Patient remains hypotensive and levofed was started at 5 mics per minute. Zosyn was started as well as Keppra. Keppra for brain protection. It raises your seizure threshold. A temperature probe was placed using the existing Foley catheter. Cooling measures were taken. Initially, ice packs placed axillary on the lower abdomen, later replaced by a machine called the Arctic Sun that I will show you in a second. Due to persistent use of levofed, patient does have an arterial line placed in the right wrist for continuous monitoring. So anytime you're doing any sort of hemodynamics, you want to make sure you have a constant look of that pressure, and arterial line is the best way to do that, other than your non-invasive pressures. So this is your Arctic Sun. There's what it looks like. Attaches to the patient, just cools their entire body temperature. You can actually set a temperature, and it will auto-adjust the fluid that runs through that apparatus to cool that patient to that desired temperature. And that's actually from the patient's room, set to a temperature of 37 degrees Celsius. You can see all the pressure monitoring here. If you actually look, this is your arterial line, right? So there's a lot more time low than there is high. It's actually a 2-to-1 ratio. Again, that is your whole map, right? You're lower more percent of the time than you're high, which is your mean arterial pressure. That's how you calculate it. Your ICP monitoring, right now it's a flat line. Once I show you the apparatus, it'll make more sense. You have the option of either monitoring or draining. You cannot do both at the same time. All right, and there's all your invasive monitoring. The initial physical exam, patient had a GCS of 3, unresponsive, airway protected by an endotracheal tube, breathing on the vent. No present spontaneous respiration, skin dry, normal, hot to touch. He has a ventricular shunt placed, pupils are 1 millimeter unreactive, noted horizontalness, stagmus. We'll go over that in a second. That's important to know for any neurobleed. No JVD, and the trachea is midline. Chest is intact, good chest wall movement, absent breath sounds on the left side of the chest. Clear in all fields on the right side of the chest. Note was made to the nurse. Here's one thing important, even on an ICU level patient like this, with midlines, with central lines, with arterial lines, ICP shunts, monitoring, go back to your basics, right? Basics is what saves lives. This patient's been satting at 81% for a moderate period of time at this point since the OR. Why? We're taking breath sounds. There's no breath sounds on the left side of the chest. Now, anyone who has learned intubation is starting to think what I was thinking at the time as well. Abdomen unremarkable, pelvic has catheter present, extremities, non-palpable peripheral pulses. Why? Because the systolic blood pressure is so low. Flow was confirmed with a Doppler. So one thing that you can use in your tool to see if someone is perfusing or has that blood flow is a Doppler. And that's how they confirmed that this patient was indeed perfusing his extremities. There's a no neurologic deficit. So you're not able to adequately test sensory and motor deficits. The patient does have a Babinski. So one thing that we learned, pediatrics up to the age of 2 have what's called a Babinski reflex. When you kind of almost tickle the bottom of the foot, and I'll show you this in a second, if they curl in, that's the normal, that would be an adult. The Babinski reflex would be to extend out. The way we think of that is babies like to show off, so they like to show off their toesies. All right. So this is only present on the right foot, not the left foot. And I'm going to show you that in a second. So this is nystagmus. So if you ever look and someone's unresponsive and they're showing one of these, it's usually indicative of some sort of intracranial pressure or some sort of brain abnormality. So this is the Babinski reflex. So I'll play this for you again. All right. So you see, this is the patient. This is actually me putting my hands on this patient's sock. So you see how he extends up instead of curling down? That is a positive Babinski sign, which is not good for an adult patient. And there you can see it as well. So this patient's on actual vent setting. So he's on PRVC mode, which is pressure regulated volume control. which is a volume control mode where it titrates how the pressure is delivered to offer the maximum compliance out of the lung. Again, I recommend reading up on ventilator settings if you want to know more on that. It goes beyond what I'll be able to get you in this lecture. Pressure is on a flow trig of 2 liters per minute. This is a problem. Flow triggers need to be negative. When you're setting up a vent, if a flow trigger is positive, it actually means you have to exhale to initiate a breath, which is obviously not possible. If you have a negative flow, when you're inducing a negative flow in the ventilator, it knows that you are trying to draw a breath and it will then deliver a breath to you. Current IV drip medications for this patient. He's on a sepsis workup, so he's on his 30 ml per kilogram bolus of LR. He's on Levophed. That's how it's prepared. We do 4 in 1,000. They can do 4 in 250 in the hospital, usually through a central line, right? Where they're not worried as much about extravasation when they're dealing with a central line. There's your Keppra, 1 milligram in 100 over 15 minutes, and there's Zosyn as well for your sepsis workup. One thing we can see here, you can see all these little mini points. These are not so neat looking, what's called a Carrari cleft. This is the patient trying to initiate a breath, but is not being allowed to by the ventilator, right? So again, that has to do with the fact that the flow trig was set to a positive number. This patient's trying to initiate breaths and is just not able to. And again, we'll make note of that later. So this is the patient's initial labs. All right. So if you go back, bicarb, little low, nothing crazy. Bun's high, creatinine's high. Less than the ratio. Again, remember, greater than 20, pre-renal failure. Inside of 20, likely indicative of intrarenal failure. All right. Glucose is also elevated, 264. Calcium's also a little low. Lactate's 4, right? So lactate 2.5 is where they really start thinking sepsis. 2 to 2.5. Lactate of 4 is severe sepsis, right? So this patient now has multiple organs that are starting to fail. So this patient's now becoming a MODS patient. Now your CBC, elevated white count, again, indicative of sepsis. Platelets are a little high, but not considered elevated. And again, this patient is compensated metabolic acidosis, right? So the CO2 is a little low, compensating for your bicarb. Also, something of note as well, this PO2, when we talk about oxygen toxicity, which isn't talked about pre-hospitally, when we say, you know what, maybe we don't want to give a patient oxygen, this is what we're talking about. Your PO2 really between, 80 to like 120-ish is really your ideal. So we're way too high on the oxygen right now. So we can actually back off of the FiO2 because it's not actually an oxygenation issue that's causing his low pulse oximetry. It's a ventilation issue. So this is the patient's chest x-ray. So again, we had no lung sounds on the left side and good lung sounds on the right side. So this note was actually made to the nurse. I actually went up to the anesthesiologist who had intubated this patient and said, hey, you should check the lung sounds out. I was trying to be nice, but no, he wanted to wait for the chest x-ray. Now here is your ET tube. All the way down here. This is the carina. 5 centimeters lower than that in the right lung is the end of the ET tube, which is why the patient was saturating at 80% for as long as he was. This tube was withdrawn 5 centimeters to a depth of 26 at the lip, and the oxygenation increased. So again, BLS before ALS. So that was prior to shunt placement. That was post shunt placement. It worked. You can see that open ventricle on the right side now. So this patient has sepsis secondary to a UTI, also has a ventricular bleed with risk of intracranial pressure, increased cranial pressure. This is an ICP monitor / drain. So we can see over here, this line will indicate how we set up that kind of pop-off valve, right? So anything above that, it'll start draining. It works purely by gravity. It's a very simple system. All of this is CSF. It's weird seeing it out of the body. This also connects, if you see this line right here, over to the transducer, which is how we would then, depending on where this is, if this is shut off to here, we're getting ICP monitor values. If it's shut off to here, it's draining. Again, it's one or the other. And again, just like I said, it acts kind of like a blow-off valve. And that's how it was placed. So one thing, actually, I'm going to go back really quick. If you're doing transports with these, it's very important to shut off the flow to the patient prior to moving the patient. Because if this is not properly level to the patient, you could massively increase or decrease their intracranial pressure purely based on where this is sitting. So again, it's important to shut it off and then you'll turn it back on once you can level it out. Also poses an additional issue with flight when things can become very imbalanced very quickly.
We're now going to talk about how to monitor intracranial pressure using your external transducer. And this is a good time for me to remind you that an external transducer needs to be 0 to atmospheric pressure, and you would do that in accordance to your hospital protocols. In order to get your ICP reading, you'll need to turn your system stop clock off to the burette so that it's in the monitoring only position. And you may be recording this information once an hour, or you may be getting continual information depending on your physician's order.
All right, almost there. Hold in with me. All right, so alternative treatments. So this check essentially should have been done immediately when this patient got brought up to the floor. It was a presumed right mainstem intubation because of low O2 saturation, the BLS assessment of absent left lung sounds, delaying the x-ray, delayed appropriate care. Again, when pre-oxygenation was at a premium, especially with the increased ICP and reduced MAP, it's vital that this patient was getting all the oxygen that he could have, and he wasn't, which definitely did not help. Vet settings also are inappropriate. Again, so you can base your vent settings based on what's called Winter's formula. So this is important. Whenever you're dealing with a metabolic acidosis, this is how you do it. You take your bicarb times 1.5 plus 8, and then plus or minus 2 is going to give your ideal end tidal. So the ideal end tidal for this patient would be 35.4 to 39.4, and it's currently 33. So the patient is being overventilated. They're blowing off too much of that CO2. Again, this is based on pH alone. Consideration for ICP could have also played a factor. Again, you might keep a little bit of a lower CO2 to keep that pressure down. Although we are actively draining the CSF, so maybe it's less of a concern with that shunt. Any sort of reduction should be reduced in rate first, as long as the patient doesn't overbreathe the vent. Then you can go ahead and you can reduce the volume as well. The patient currently has a volume of 6.6 mLs per kilogram, so reducing to 5 could potentially work as well. But again, now you're at the bottom of what this patient should be ventilating at, right? 5 to 10 is our goal. So again, the FiO2 can be titrated down. The PR2 is a bit high, although later in the shift, if it was above 100, the patient doesn't have an oxygenation issue. It's purely a ventilation issue. And again, we also mentioned the flow trigger before, that having a negative flow trigger is necessary for the patient to initiate their own breaths. Leave it fed also could have been started sooner, again, with the premium being on good cerebral perfusion and the patient being hypotensive, they could have started it sooner as well. Also starting a central line with this kind of pressor, as well as all the other meds that we're running, probably would have been better as well. They were running all of this stuff basically off of an IV. I believe they had a med line and an IO. A good option for this patient could have been either a triple lumen. They did not want to do the triple lumen because they wanted to keep the cephalid vein or the internal jugular vein accessible should they want to initiate a hemodialysis shunt, because this patient is in renal failure. But then they could have easily offered, femoral. Again, the contraindication to a femoral lumen would be infection risk, but there's patients already under a sepsis protocol as well. Again, these are just some of the different sites that you can do central lines. Patient overnight went hypertensive, was obviously taken off the Levofed. Patient maintained hypertensive, and they actually started nicardipine. So the working diagnosis now with MODS, he has renal failure, intrarenal failure, he has sepsis, he has CNS depression. So he's now at least on 3 systems of MODS. No real noted physical exam. He has some movement in extremities, not very purposeful. He will move a little bit to painful stimuli. So this is how the nicardipine was prepped and administered. Again, LR going, Zosyn. Vent settings. Patient's overbreathing the vent now, so you can see the patient's triggering at 24. So the patient's taking 8 extra breaths a minute. You can see the FiO2 is dropped, which is good, but they still are asynchronous because they still have that positive flow trigger. And again, these are the values day 1, day 2. You can see everything at least starting to come back into range for the most part. And again, the ABG, again, everything kind of coming back into range for the most part. CO2, they were still on AC mode, so the patient's overcompensating on the vent. Perhaps if they switch to SAMV mode, you would have less of that. But again, you can see the PaO2 kind of coming back into range a little bit, a little low now, actually. So you might need to go back up on the FiO2. Almost there, guys. Mortality for this patient, initially, I would say between 50 to 80%. Unfortunately, the additional complication of prolonged hypoxia from the unrecognized or unrecognized by people who can do things about it, right main stem, likely further increased brain injury. The likelihood of an anoxic brain injury with survival is present. Again, the delay to appropriate surgical intervention. This patient sat in the ED for, I want to say it was 2 or 3 hours before any interventions were taken. Really probably did a lot of brain damage. So this ED doc really did a disservice to this patient. Again, don't get that tunnel vision. Don't always go with your first diagnosis. Have a bunch of differentials to check out. If this patient does survive, it's very unlikely they'll have any meaningful brain activity. With that, in addition to the past medical history, I'd put their mortality somewhere between 90 and 99%. It's unfortunate. The next of kin was set to arrive 2 days later, which will obviously determine the further course of care. Unfortunately, again, this patient has little chance for recovery, and should they recover, will probably be on the ventilator for the rest of their life due to any potential anoxic brain injury occurred. One thing that I was not a huge fan of is the nurse that was taking care of this patient on the second day when they got in contact with the next of kin did not give the full, or rather they sugarcoated the patient's diagnosis. I personally believe that's unprofessional and can cause more severe psychological complications for the next of kin. It's important to be delicate when handling difficult news to loved ones, but I think it's important to be accurate. Again, this is something pre-hospitally we use on a regular basis when it comes to patients that are deceased. Oftentimes we go, whether it's they are deceased with no resuscitation or deceased with a resuscitation attempt. It's often difficult to be completely honest with that loved one, but it's important to let them know, we did everything that we could, but this patient has died. Be explicit. Don't leave any room for misinterpretation. And I think as much as it hurts and as much as they might be upset, they're not upset with you. They're upset with the circumstance. Again, the social psychological impact will likely be isolated to the next of kin. This patient likely has not had any meaningful consciousness since the initial bleed. And again, next of kin will have to adjust to a more accurate diagnosis and then make further clinical decisions for this patient. Also, something to keep in mind is the cost of an ICU bed. Nationwide average is about $25,000 to $35,000 per day. The patient's assets, let me just move this so I can read it, will basically go against this debt. The laws by state do vary, but the next of kin themselves won't directly have the financial impact. So being able to use a ventricular shunt, I thought was very interesting on this patient, analyzing all these images and anticipating the clinical course. Seeing basic neuro assessments, something such as the Babinski that we don't usually see on adult patients, I thought was quite interesting. We do have many patients who have CVAs or CVA mimics on a regular basis. In this case, we were seeing a very confirmed bleed and watching the clinical course be ran out in the ICU level of care. Trust your BLS skills. Confirm with imaging, but trust your BLS skills. Also learned with the ICP drain and monitoring. Proper ventilator settings. Prophylactic Keppra for risk neuro. Accurate reports to healthcare and family. Maintaining multiple invasive monitoring. For those who don't know, our life pack is capable of doing 2 invasive monitorings. The Zola is capable of 3. All right, bonus slide. Can anyone tell me what this is going on?
That's reflection.
Close? Mr. Baskin says reflection. These are fillings. These are teeth fillings you're seeing on a CT scan. All right, any other questions? Hopefully you got something interesting out of that, learned something, took something away from that.
Very interesting.
If there were things that were above and beyond, if you have questions, you can reach out to me outside of this presentation as well. I encourage you to look up things that you don't know or want more answers on. And I encourage everyone to don't learn to your level of care, learn above your level of care, because that will, that's how you improve as a provider. So hopefully we all learned something. We all got something out of this, had fun, and saw 2 very, very different and interesting ICU level patients. And thank you all for coming. I appreciate it, and have a great night.
Thank you, Kyle. It was nice job. I'm definitely doing Babinski's.
Very nice, Kyle. Thank you.